Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind Podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. So, welcome back from our sort of small summer break thing we did. I'm delighted to have Derek Donegan on the podcast with us today. Dr. Donegan is an orthopedic trauma surgeon. He's the associate professor at the University of Pennsylvania and is the healthcare entrepreneur focused on advancing surgical care, technology, and physician well-being. He's a co-founder of OR Intelligence and serves in the national leadership with the Orthopedic Trauma Association, where his work centers on well-being, moral injury, and advocacy. And if you're watching me read that off the side of the screen, that's just because I want to get all of that exactly right. Most importantly, I think Derek is a brilliant leader and a clinician and somebody I'm proud and happy to call a friend and happy to have him on the podcast. So Derek, welcome.
Thanks, Dan. It's a pleasure to be here, and it's humbling when you hear somebody read that. So thank you.
Yeah, absolutely. We've had over the years a ton of super interesting conversations. We've done some projects together. We're in the middle of doing some projects. There's a lot of really interesting ground to go over for this. Why don't we start, if folks haven't met you and they don't know you, can you give us like a 30,000-foot view of, or the metric system, if you prefer, of what you do and who you are?
Sure. As Dan said, my name's Derek Donegan. I am a practicing orthopedic trauma surgeon at a fairly busy level 1 academic trauma center in Philadelphia at the University of Pennsylvania. I've been in practice, I think I'm just starting my 15th year or so as an attending surgeon. That role is very vast, a couple different hats. Number one, obviously, is clinical care, taking care of polytraumatized and trauma patients that come in through the ER to trauma bay, who injure themselves and come into our clinic. In addition, because it's an academic center, we get to do research and study things that can hopefully advance our field and make things better for our patients and for other providers. And lastly is I get to educate. I get to educate medical students, residents, and fellows. And so when you think about the ability to have impacts on the systems and people, this starts to really broaden the ability to touch people in many different ways. In addition, I'm happily married for 20 years and a proud father of 4 incredible daughters that keep me very busy outside of when I'm not working as an orthopedic trauma surgeon. And then, as Dan also mentioned, I have a passion for the entrepreneurial spirit to bring kind of more visionary things into the healthcare space to really just to make our jobs a little bit better and to provide better care for our patients.
Love it, man. I love it. I'm thinking back of all of the conversations we've shared over the years, and they usually involve stealing 5 or 10 minutes in between things, which is no surprise given the list of the depth of what you do. I think it's worth starting with what is ortho trauma. And I think that's worth it because I'm not sure the breakdown is the same in other places. And it's worth defining what it is because I think it's going to be one of the themes we poke at is what does it take to be a good ortho trauma person and how do we build that or what does a system look like that? So what is ortho?
Yeah, that's a great question, actually, because I think people don't necessarily understand the different types of orthopedics that can be practiced, if you will. So, orthopedics in general is basically being a surgeon of the musculoskeletal system. And most people think of that as doing hip and knee replacements, reconstructing ACLs on athletes, taking care of some wrist fractures, carpal tunnel releases, etc. But when you start to dial into orthopedics, there are multiple studies where people take an extra year of training to really hone their skills in a specific area. One of those areas is orthopedic traumatology, which I developed a passion for and chose to pursue in a little bit of a deeper dive. And what that really is taking care of the acutely injured individual from a musculoskeletal perspective. Most commonly broken bones, whether it's a femur fracture or a tibia fracture or a wrist fracture or forearm or humerus or pelvis or an acetabulum, those types of injuries. But what kind of separates the orthopedic trauma surgeon is when that all happens in a very high energy mechanism in a patient who potentially could be in extremis when they come into the hospital, for lack of a better term, on death's door. And part of the reason is because of these musculoskeletal injuries that they have. And so we spend a year of really focusing on how to manage that person as a whole, how to manage their injuries, and how to start to put those people back together.
So there's a couple threads that I want to pull on here. And maybe let's do it this way. Can you describe the difference between the setup for and maybe execution of what somebody would do if they're, say, replacing a knee in an elective surgery versus if they're doing a femur repair in somebody that was hit by a car.
Sure. I think, and that's a really nice contrast. Technically, doing hip and knee replacements can be very technically challenged, and our surgeons that spend time becoming experts for that are truly gifted. But when you look at doing an elective total hip or total knee replacement, it's planned, right? You meet the patient in the office, you diagnose them with, say, knee arthritis, and they failed conservative treatment. And the decision is to proceed with surgical intervention in the form of a total knee replacement. That person is then booked for surgery, usually 4 to 6 weeks out, maybe even longer. And in that time period, that patient is able to become medically optimized as well. They can see their medical doctors, they get cardiology clearance, make sure their blood sugar is under control. If there's any habits that might negatively affect outcomes like smoking, things of that nature, can start to work on reversing or quitting those. And then their surgery date comes. And from a surgeon's perspective, if I'm doing hip and knee replacements all day, my schedule is patient A, total knee, patient B, total hip, left versus patient C. And it's very predictable and scheduled. And then the case itself tends to follow pretty specific steps with similar, if not the same equipment, most times in a very stepwise fashion. And so the people who do that are true wizards of their craft and can become extremely efficient at that surgery and really optimize outcomes for their patients. On the flip side, orthopedic trauma. Now, there are some elective cases we get to do when trauma goes sideways, when bones don't heal correctly, things of that nature. But in the acute setting, the person with, say, the femur fracture who crashes his motorcycle, they come into the emergency room or the trauma bay, and they could potentially have other injuries going on. But from a orthopedic surgery perspective, that patient is added on to the OR schedule either that day or the next day and taken to the operating room by an orthopedic surgeon or traumatologist to fix their femur. Now, an orthopedic trauma surgeon, if it's just that one femur that came in, that's all they're doing, but that tends not to be the case. Where my day is often fixing a femur fracture, fixing a tibia fracture, fixing a proximal humerus fracture, fixing a pelvis, maybe doing a conversion total hip for a failed acetabular fracture. So my orthopedic trauma surgeon's day is fairly unpredictable. And I would say one of the things I personally like about it, and I guess this will get to my personality, is I can go to bed and have 2 cases on the schedule and wake up and have 10. And you just have to be able to roll with that, think on your toes a little bit, and be okay with planning. You're going to plan and prepare, but with limited time to do so.
So when we go back to the joints person, we're thinking about, I love how much you used the word optimize around that. And I think there's this whole concept of like in the OR, you're optimizing technique, you're optimizing kits, you're getting really familiar with what you're doing, your team's getting used to it, you're getting a battle rhythm of that same thing down. And then even outside of the OR, you're really optimizing the environment, both of scheduling and getting the person in there, but also of the human being, right? You have time to work to make the field better to play with, right? To make the human better to work with. Versus in your life where you get the hand of cards that you get, so does the patient, right? Nobody necessarily wants to be there, right? But you all get the hand of cards you're dealt, and then you have to figure out how to play it with what you have. And over the years that you and I have known each other, I've been endlessly fascinated by the training pipeline that in some ways produces both of those people from the same training pathway. Now, obviously, there are differences, right? There's fellowship, and you do a fellowship in trauma, or you do a fellowship in joints, or sort of whatever. But at the end of the day, most of the training pipeline is all of the orthopedic folks together versus, say, the OB-GYN folks or the pediatrics folks or me in the ER. And there's some pathway that takes people that love surgery, they love the musculoskeletal system, and they want to be in this space. And you train them how to think through these problem sets, and then they decide somewhere in there, I really like unordered, unstructured, chaotic problem sets. I want to wake up and have 10 things and not know what they are, and want to work on somebody that's not optimized, want to be in the mess of it, versus, you know what, I actually want to be the world's best at performing like left ACL repairs. And I want to be like so good at that I want to control all the variables and make optimal really within my grasp? And how does that work? Right? Like, how do you produce one pipeline that are you bringing both of those people in preformed and then they know from the time they hit the door that they're going to go left or right? Or are you seeing people that all come in and then somewhere along the way they catch a spark and they're like, I really want to go this way? Because I think there's an underlying question there about, in general, how do you train people to work in the types of environments that you work in where you have to love some of that chaos to really get it done?
Yeah. So I think you hit the nail on the head. The training pipeline is pretty similar, right? Graduate college, you get into medical school. At some point in medical school, you decide that orthopedic surgery or whatever specialty is the specialty you want to go into, and then you apply for that residency, right? So whether it's an emergency medicine residency, internal medicine, orthopedic surgery, whatever. So there's a selection process that goes into that, right? And so the people who say, I want to be an orthopedic surgeon, they apply to orthopedic surgery residencies. I think the last time I looked at the statistics, maybe about a year or two ago, it was something like, I think 20%, 23% people matched into orthopedics. So to give you a real reference, at the University of Pennsylvania, we have 8 residents per year for 5 years. So there's 8 spots. We tend to interview somewhere around 80 people for those 8 spots out of probably about 1,000 people who apply to our program. So that field becomes very narrowed very quickly. So then we get these 8 people who have decided they want to become orthopedic surgeons. Some come in with, and everyone has different reasons for it. Some have a family member who's an orthopedic surgeon. Some people underwent orthopedic surgery and some know someone who did and they just really changed their lives. Some people just like working with their hands and tools, right? And so it's pretty diverse. And some people come in and say, hey, I want to be the best left ACL surgeon, right? Some people come in and say, I have no idea what I want to be. I just want to be an orthopedic surgeon. And so I think there's both. You have people who come in and have a very clear identity and identity path. And then you have people who come in are a little more open and a blank canvas, if you will, and they tend to catch that spark of whatever that may be. And I think it's really important. And sometimes it changes. I'll give you, for example, for me, I was a collegiate wrestler. I was a phys ed teacher. I coached wrestling all before going to medical school and making that decision. So in my mind, the most logical thing for me to do was to be a sports medicine surgeon. Just made sense. And I caught the trauma bug when I was a PGY 2 and 3 with a couple very specific experiences that I was like, wow, like this is what I want to do the rest of my life. And I felt very rewarding and very fulfilling. And so that can happen. But it can happen where someone says, hey, this fits my personality better. And I think that's also a really important thing. It's something that we in the academic environment try to, coach slash mentor, whatever word you want to use. There's some nuance behind that. But be an advisor saying, hey, this is what this is really. And it becomes that immersive experience that when you're on trauma for 6 weeks, like you're doing nothing but trauma, you know what it's about, right? You get to understand what that lifestyle is for a short period of time and hopefully be able to make a decision of, I can do this for the rest of my life or not.
And how does it work? I will ask this. Please feel free to decline answering this, but how does it work at the department level? Because I have to imagine that the personalities and problem-solving tools and ways of looking at the world between different types of orthopedic surgeons who do or do not favor chaos are probably a little different. And so collectively, you all still have to run a department together and you have to run a ship. So you have these people with very different sort of mindsets. Unlike, to some degree, say, an emergency department, where basically everybody in an emergency department is emergency. And we all, for better or for worse, have some of the same personality traits. And that can really trip us sometimes, or that can get us all running in the same direction. But how does that work from a systems point of view?
That's an interesting question. I'd have to say, I think it just works. And I think the reason why is because it takes all kinds for the system to go around, right? I think we need the people who are able to focus on doing a 10-hour spine surgery, and that's all they do, right? Because there's patients out there that need that.
Absolutely.
We need the people who are like, hey, listen, I just want to do my total knees and total hips because I can get that surgery done and my outcome's going to be the same. Like I know what it's going to be. And one of our surgeons say, same as same, right? Same as same. I'm good. That's my lane. And then there's people like me and my partners who are like, let's bring the chaos because we need chaos organizers, right? Because we're in a trauma
Sure.
center. And so I think it just works. Hats off to my chairman, Kyle Potter, for the one who has to deal with all of us, right? And be our boss in quotes, right? Because it's a lot of different personalities and a lot of different egos and all sorts of things that you have to get people rowing in the same direction. But it seems to work.
Love it. Okay. We've been so far sort of contrasting two different styles of orthopedic surgery, for lack of a better word, two different directions of it. But let's zoom into yours for a minute. And you can't optimize the patient before they get there because you don't know when they're coming. You don't necessarily know what's going to be wrong with them. And so you're handed, and I know this isn't quite literally, but you're handed a card, and the card says you have to do this procedure on this person, basically in this way. So what are the control surfaces you have over that space? And we can, the joints folks can control all sorts of stuff. What are the control surfaces that you have when all of a sudden you have to come in and do a thing?
Yeah, I think it depends on time of day, right? And so I think we've been very lucky to set up a system where we can get the majority of our work done during, I'll call it working daylight hours, right? Where our teams, our surrounding casting of characters, our circulating nurses, scrub techs, is X-ray techs are, for the most part, similar, right? Not exactly the same every time, but same enough where we can rely on some consistency there to know that, okay, if we're taking care of somebody's femur fracture, we're going to put an interventional nail in it, that they know how we like to set up the room. They know what instruments that we're going to use. Our scrub tech has some familiarity with the instrument sets that we're going to use. Our anesthesia team knows that patient needs a paralytics on board for us to overcome the forces of the thigh muscles to get our reduction. And so those are, I think, the things that are in our control. We have no control over the fracture type, whether it's complex, simple, open, patient type, as you alluded to. They could be morbidly obese, they could have substances on board, all sorts of things, not an optimized host. So I think optimizing the process as best you can with the people around you allows you to have an efficient, optimized surgical process that, regardless of the card you're dealt, is going to set yourself up for success as much as possible.
For all of us in medicine, when we join a team, we modify the environment around us, but we also inherit from that environment, right? Almost none of us design a new system from the ground up. But if I could give you a magic wand for a minute and you got to completely remake a hospital, all of a sudden, here's your brand new hospital. It's going to have the same sort of input of patients and inflow of stuff as you do right now. What sort of systems would you want to change in that? Or I guess an equivalent way of looking at that is if you're thinking about the system as the way to control the surfaces that you can control, what do you look for when you're evaluating that?
Yeah, I think the biggest one is the consistency of teams and resources. I think that's where the wheels start to fall off the bus a little bit anywhere in any system, right? It's in our optimized environment, things are, even in unpredictable situations, things are fairly predictable, right? In my mind, I know when a case can start to go sideways and dial in my senses a little differently, right? And when it's the consistent team members, that's something I can specifically focus on. When we start to get outside of that, when, say, shift change happens and those team members start to become different, sometimes it works out fine, sometimes it doesn't, just because that's the nature of the beast. Those other factors start to play a role in our ability to efficiently do our job. Let's just say, for instance, we're taking care of someone's femur and person came in, they need to get fixed, and it just happens to be, say, 8 o'clock at night. And it's a new shift of people. And just unfortunately, the person who's a scrub tech, say, has only done that case maybe twice before, right?
Sure.
And so now my focus not only is on the patient, it's also on the scrub tech, making sure that we're getting the right equipment at the right time for the right reason and that it's functioning properly. So it starts to dial your senses, or I should say, dilute your senses away from probably the most important tasks. Now, that being said, you do this long enough, you start to understand that and you change your style in those moments, right? And if I think that people who have been doing this long enough and that are successful at it can see that and see that coming and have a different way of working, right? Can adapt to that environment to still optimize outcomes.
Can you press on this? Could you give us an example of what would you do differently, or what type of thing would you change in that moment?
Yeah, I think fortunate to have a couple people in the operating room with us. And so if at that time, if I have a medical sales consultant for trauma, and actually almost of all of orthopedics that are very implant dependent, companies have representatives that kind of bring the implants in, or are, we'll call them set experts for lack of a better term. If I have somebody that I trust on that end, I can have a conversation with them ahead of the case, like, hey, this our scrub tech is a little new, like newer to this, has only done this a couple times. I need you to be like super engaged. You need to make sure that like you're guiding them through this is the right. When I ask for a guide wire, the correct guide wire. When I ask for a drill bit, this is the correct drill bit. And so those are things you can start to dial in a little bit. Additionally, being in an academic teaching center, we have a obligation to teach our residents to be able to do these procedures as well. And if there's certain variables that I can't control, then those are the parts of the cases that I need to make sure that maybe I'm doing right, because the instruments are in my hands, because it's just one more variable that I can't control. Right. And so I think bringing in as much of that you can control in this situation is helpful.
There's a, I don't know that there's a good word for it, but there's a sense, and I literally mean that sight or touch or whatever. There's a sense that people who work in this space develop about the moment to moment feeling of the uncertainty that's around them, right? And there's a way that you can just feel what that is. And I think you're describing some version of that right now, right? There's the uncertainty is bounded, right? You know, you're going to be working on an orthopedic problem. It's unlikely anybody's going to call you over to the CT surgery side of the room and have you work on somebody's heart, or you're not going to be intubating with me down in the ER, right? You have a sense like, I don't know what's coming in, but I know it's going to be somewhere in this field. And that allows me to deploy experience and repetition to within these spaces and to get a sense of what right looks and feels like. And then I can start feeling the quality of the uncertainty that's in there. A lot of the work from Gary Klein's team, the naturalistic decision-making world, starts feeling about this, like, what is your sense of normal and how do you know when something's drifting from that? But I think it's interesting to describe that idea that there's a systems layer to that and a personal layer to that, right? So you're describing the systems layer of what is the experience of this team in this operation, in this space. And then there's a person layer to where you're like meta watching your own attention and where it's going, and you're adjusting that control surface inside of you. I have a billion directions to go from that, but I'm curious, what does that match what you're feeling on the inside there? How does that sound to you?
100%. I think that's said very appropriately. I think this kind of, what do we call it, the tacit knowledge transfer problem, right? This is just experience. It's one of those things, and it, no matter how hard I think we try to teach it, it's a matter of you almost just have to do it and be there and experience it enough time for that. I call it my Spidey sense. My Spidey sense is up. It's a feeling, it's a gut. It's like, okay, hey, this is like really the critical part of the case. I'm going to do it, because if something goes sideways here in this current environment, it could drastically change the outcome. Right. And so it's just one of those things where like, yeah, it's a sixth sense, if you will. But it's also one of those things that's really important for us to try to teach, right? Where it's like,
Absolutely.
and so we're fortunate enough, we get to work with residents through all first year through fifth year. And so when our chiefs are with us, it's one of those things where even if, you know, if you can call it out at the time, they can hopefully start to pick it up, right? Hey, I'm going to do this right now because, and you just give like a very brief 2-second, whatever. And hopefully they can start to pick some of that stuff up.
It's interesting the way you said that for sure there's tacit knowledge here that it's very hard to transmit because we don't have the language for it and we don't have the structure for it. But I think that it's easy to lump a lot of stuff under tacit and to not poke at it. And I'm not saying that accusatorily because you and I have had these conversations a bunch, right? But it's interesting what you said a second ago was your reasoning for it, which was, I'm going to take over because I know if this thing happens in this situation with this environment, it could produce these outcomes. So there's some sense in there where the data streams that you're melding together are what the normal case looks like, what the environment looks like, what the cone of future possibilities looks like. And you're comparing that against some sort of a risk surface or a risk map. And that's, if you had to explain it, those are some of the data streams and sort of operations that I've put in your mouth as you're describing it, right? But what else would you put in there if you, and I'm going to give you an impossible challenge, right? Literally an impossible one, which is, all right, you got to train a robot to do this, or you got to train an AI system to do this. What else would you put in there?
Yeah, it's interesting, Dan. This is my argument for why I don't think AI will take over all aspects of surgery. Because there is a component of feel and experience that I think is really important. It might say the right thing in this situation is to do X, but if you can't do X, like you're not physically capable of doing X, then X probably isn't the right answer. Now, a robot might be able to physically be capable of doing X, so that might eliminate that conversation. But you have to use your experience of what you know you can do and what you can do safely to help that patient at that time versus not, right? I should not be exposing and decompressing somebody's spine. That's just not me. It's not my wheelhouse. As
Shouldn't be
my
either. Let's be clear. Yeah.
Yeah, my internist probably shouldn't be fixing a femur fracture, right? But he probably doesn't want to read me reading an EKG. It's fair, right? It's all good. We have our kind of areas of expertise. I think the interesting things that the there is a way to, I think, verbalize it and call it out. And as I think you do that more, I think the knowledge transfer becomes more, it can become explicit, right? You can develop the words behind it, even if it's just, hey, it's a feeling and this is what I'm seeing. And so I think that allows it to hopefully come across a little bit. But I think there are situations where it is an experience thing that's really important. It's hard to replicate.
Yeah, there's an internal component to that requires you as the expert to pay attention to what you're feeling and to surface those signals. And then there's a guide translator component to it where you have to be willing and interested to verbalize out loud, look, I don't know how to explain it, but I don't like the way this feels. And then there's a learning component to it where the learners have to pick up on that and understand that's as much signal as you're going to get. And you have to figure out what to do with that space. And I think that it's hard to reduce that to language. And I'm using language really broadly here, right? Just anything that we would do to explore it or, that we could transmit knowledge in some sense with. And I know there's a ton of work that on the mission critical side about the tacit knowledge transfer problem that we've talked about. But I think it's interesting to think through, like, what are the edges of that? What are the data streams? What are the control surfaces? I'm not trying to make it all machines, but if we lean into that, what do we learn about ourselves by doing it?
Yeah, no, I think it's interesting. It's definitely different from person to person as well. I think it's part of who you are, your personality, things of that nature. I do think I've known, right? My reputation is when things get hard, I get quiet. Like when I get quiet in the OR and just start doing, things are probably more challenging, or things are starting to head in a different direction than what we want. It's taken a lot of work for me to recognize that myself, to then be able to openly talk about it in the moment. Sometimes I don't, depends on what's going on, right? But I think because the people I'm training kind of know that about me, the ones who are curious, I'll put it that way, afterwards will be like, hey, what was going through your mind? Why were you doing that? What happened? What did you see? Not all of them are that insightful, but some are. And so you're able to verbalize it then. So I've been trying to be better at verbalizing in the moment, but sometimes the moment doesn't call for that, right? The moment calls for work to be done and needs to get done and it needs to get done quickly and right. Yeah.
There's a tension between, in our limited wet brains, right? There's a tension between the amount of bandwidth we can devote to metacognition, thinking and teaching, versus the amount of bandwidth we need to devote to executing and saving a person's life or limb or whatever the equivalent is in another space. And there's a mirror of that layer of tension if we zoom out at the systems level that says, hey, we have to be prepared to operate in these ways at these periods of time. And we need to balance the amount of staff we have and the training and experience and all of the things. And there's some whatever the word for metacognition is for a system. I don't know if I'm not sure if there's a word
I
for
don't know.
that, but it's like the system thinking about how the system operates, meta operations. I don't know. Somebody listening to this will provide me with the answer of that. But
We'll know in due time.
yeah, exactly. So meta operations or whatever versus operations that the system has to execute versus improve. And we all have limited bandwidths. And to build resilient people and resilient systems that can operate in uncertain environments, we have to ride that edge a bunch. I don't know that I have a question about that, but man, is that
Okay.
interesting to think about.
Yeah, and what it made me think of, which I think is important, and I don't know where this, not, and I don't want to say this in the fact that people don't think this, because I think they do, but they don't understand what it really means. What we do is hard. It's supposed to be hard, right? And there's real consequences to when things don't go well.
Yeah.
And that can weigh a lot on a person, right? And
Yeah.
and again, I don't think there's any way I could have that conversation with you a million times, but until you experience the hard and that falls on your shoulders, it's hard for that person to truly grasp what that means. That if that makes any sense. So I think the important thing is to realize that like all these things take, number one, time to figure it out and to develop your thing. But number two is that it's hard and it's supposed to be hard. And so if you come in thinking like, hey, I'm just going to put a bunch of screws in people and things are going to be fine, maybe, but probably not, right? There's a component to it that's going to be, I need to know my stuff. I need to learn my anatomy. I need to learn my technical skills. The residents joke sometimes, hey, like those tools are like an extra, like just an extension of your hands. I'm like, yeah, I'm like, that's what they should be. Like, these are the tools of your trade. You should know them better than anybody else in the room and should be able to use them better than anybody else in the room because that's what the person asleep is expecting of you. And so I think to the things to control, to go back to our previous conversation, I think you need to do everything in your power to set yourself up for success as well, right? When you're in the middle of that case, like you shouldn't be really thinking or learning of how to use a drill for the first time, right? That really needs to be second nature by that point.
Yeah, that's super interesting, right? So we can go back to a cognitive load theory point of view, right? And be like, all right, there's the intrinsic load, the mental energy it takes to do the task, the extraneous load, which is the mental energy to buffer noise and chaos and other stuff, and then the germane load, which is the inwardly directed energy about learning and sort of forming ways of thought about what you're doing. And there is a lot of the surface area of what we do where I totally agree with you, where you should be second nature about what you're doing on it. You shouldn't be hesitating and you should just be running into it, right? In our world, it's usually a little more simple than that. The amount of stuff we do for that is, put your hand in the bleeding spot, right? Protect the airway, do this stuff, right? Move forward towards the patient unless they're covered in toxic goo or whatever it is. But there's also a lot of stuff that we do where that's impossible, right? There's just not enough time or repetition to truly develop that sense of it, right? And I think I don't know if this is a correct fact, but I'm going to say it anyway. So asterisks. Most ER doctors on the civilian side do one emergency crike in the course of their whole career. One, right? But you never know what day it is. You never know when it's going to come. That person needs you to be skilled at it, and you will do one in your entire career. And just by the sort of the law of randomness and exposure surfaces, there's stuff that I've never done that I might be called on to do. There's stuff that the person next to me has never done that they might be called upon to do. So there's some spaces where that can't be the answer, right? And I know that we've been talking about bounded uncertainty, but what does that space look like for you all? And how do you carry those things over from, hey, I want to be the best I can at what I do, to I want to be the best I can at what I do, but I've never done this. Or, hey, we invented a new tool and it's amazing, but it's your first time using it. Or I don't know what the right parallel is there.
I think that's a similar one. I think there's new
Mhm.
technologies coming out all the time that, for especially being in an academic center, often the first time or first few times using it is in our hands. I would just say, I think there's just a basic love skill set that one develops over time,
Mhm.
and your ability to apply those skill sets to new environments, I think, is how you carry over that, right? Like in your example is the emergency cric, like you understand airways, you understand how to use a scalpel, you understand its basic tenets of that do this, you understand anatomy. It's stressful, I imagine, more than anything, but you put that together and use it, right? And so I think there's a basic level of skills that you need to continue to develop. And I can't remember if I heard this or was reading this or just thought about it on my own, but the idea that you need to have a plan and you need to be prepared. And chances are that nothing that you that it's in an emergency situation or in a chaotic environment, nothing's going to go to as you planned, but hopefully it's in the realm of how you've prepared. And so I think you can't have an answer for every iteration of
Yeah.
whatever you're about
Yeah.
to encounter. But hopefully you're able to utilize your skill sets to expand that at the time when it's needed.
I like that a lot, right? I think we talk on the podcast a lot about bounded versus unbounded uncertainty and looking at stuff that feels like it's pure chaos and finding the islands in the middle of it that are more predictable or more understandable, and understanding that your job isn't to solve the whole problem necessarily, but it's to go island to island as you're moving your way through it, which is a lot of the instruction that I would give, say, a junior ER doctor who's running a cardiac arrest for the first time. Don't solve everything, just go island to island and work your way through it. But if you prepare ahead of time, hey, here are the things that I know how to do, and I'm going to create the constellation on the fly with it, like that makes a lot of sense.
And
Derek,
you might not get it right at first. Like you might
yeah,
have to go from plan A to plan B to C to maybe Z and then back to D again. And that's okay. And you just have to be okay with that.
yeah, yeah, absolutely. That not only can that happen, but that will happen, requires the obvious movement of back and forth there. All right, Derek, this is awesome. Thank you so much, man. I feel like we covered just a huge amount of ground in terms of how do you train, how do you think, and how do you operate. We invented some words, maybe, which we'll figure out afterwards. But before we jump off, I want to give you a chance to challenge people listening to this with something you want them to do differently on their next shift or their next mode of operation. To give you a second to think that through, I'm going to do our normal disclaimer, which is that nothing we do here on the Emergency Mind podcast is medical advice. Our only job is to take the best of what everybody else has already figured out about applying knowledge under pressure and bring it out to the forefront. Nothing that we say represents anybody that we work for or with. It's just us out here in the universe trying to make it a better place. And I'll add to that, if you are listening to this and you have ideas of people that would make great guests, please reach out to me. I'd love to hear it. You can find me at dan@emergencymind.com. All right, Derek, what's the challenge? What are people doing?
All right. I think a couple things. So I think the challenge is this. I think the challenge, I've been reading this book lately about four assumptions. And I think the four assumptions, which I've been trying to kind of recreate in my mind, and so this is my challenge for you, is number one, be impeccable to your word. So mean what you say. Number two, don't take anything personal. Number three, don't make assumptions. And number four, be your best self. So that's my
Love it.
challenge to the audience.
I love it. Derek, thank you so much for joining the podcast, man. It's an honor to have you.
Yeah, thank you, Dan. This was fun.